Good afternoon, everyone. Welcome to the meeting of the Universal Healthcare Commission. This meeting is being recorded. Again, if you are if you are a member of the commission, or if you'll be speaking later, when you see the panelist link, please accept the panelist link. That will allow you to unmute yourself and to speak. And now Vicki Lowe, who is the chair of the Universal Healthcare Commission, will call our meeting to order.
Squatchy, good afternoon. Excuse me. Welcome to the October meeting of the Universal Healthcare Commission. I call the meeting to order at 2:03. And I'll begin with a land acknowledgement. I would like to begin by acknowledging that as we gather today, we are all on the ancestral homes of Indigenous people. Today, we meet on the lands of Indigenous people across the state. Here in Olympia, we are on the lands of the Squaxin Island and Nisqually people. Indigenous people, despite being removed from the lands where they lived, hunted, gathered, practiced ceremony, and cared for their community members. And Indigenous people and tribes, whether officially recognized by the United States government or not, continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands, of children stolen to boarding schools, and of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington state. As we work to improve health in Washington state, it is imperative that we address the inequities of the past by understanding their impacts on the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you reside. Thank you. I would like to begin by giving a warm welcome to everyone for joining us today, especially on I think one of the first really chilly days of the year. Today is Representative Parsley here? Yeah. Oh, so we won't be we won't be welcoming our new member yet. And then also Patrick's not able to join either. Okay. All right. So as you know, we have some open seats on the commission. Oh, okay. Representative Parsley's here? Okay. All right. So today is Representative Parsley's first official meeting as a commissioner. She was able to join us for the Advocates Roundtable, which was a special meeting last August. And so we'd like to welcome Representative Parsley. And if you want to say a few words, we'd like to give you some time for that, Representative Parsley. Did she make it over? Okay. Representative Parsley or any commission members who are joining online, in order to make you someone who can unmute and speak, you need to accept there's a box that comes up that accepts being a panelist, and that will let you into the meeting as a participant. Okay, we'll just keep moving on and see if she gets into the meeting. And so as I was saying, we do have a few open seats on the commission. 2 of the vacant seats are governor appointed, and 1 is a member of the state Senate. HCA staff has reached out to the governor's office and the legislature about the appointments for the vacancies. And I think we'll move to roll call if we don't have. Yeah, okay. Roll call.
Okay, thanks, Vicki. Calling people out by first name, alphabetical by last name, but we'll just go with the first names. Joan.
I'm here, thanks. I thought I'd missed it, but glad I didn't. So good to see everyone.
Great. And Jane. Here. Senator Cleveland, who let us know ahead of time that she's very unlikely to attend, but Senator Annette? Okay. Nicole?
Hello, here.
Okay. Dave?
Dave here from the Healthcare Authority.
Okay. Dr. Tao?
Tao Kongjet from DOH is here.
Okay. Badisha? Badisha? Okay, we'll check back. Representative Lisa,
I'm here.
you made it.
Well,
Yay.
yes, and I pushed accept to be a panelist and it's not moving me over and it keeps coming up and asking, just to let you know.
Oh, although if you're able to unmute and speak, I think you are now a panelist.
Well, no,
Oh,
it asked,
okay.
it said you said you guys could, you unmuted me and was that okay? And I said yes.
Okay. Allie worked her magic. That's what happened. Patrick. Patrick also let us know that he was unlikely to attend today. Representative Joe
Yes, I'm here. Thank you.
and Mohammed. Mohammed. Okay, we will keep an eye out for folks who may be joining a little bit later. All right, Vicky, now it's to you for a vote on the approval of the September meeting minutes.
All right. If you go to the, oh, sorry, I had it open. Your packet in the first section under tab 1, yes, is the September meeting notes. We had some public comment. We talked about interstate healthcare compacts. There's got state agency updates. We talked about the budget, work plan, and charter update. Got an update from the Financial Technical Advisory Committee. Mary gave us some governance examples. And then we had a very short discussion on next steps because we ran out of time. So I'm looking for, is there any edits or comments on the notes? And if not, I'm looking for a motion to approve.
Just one edit. I think I'm omitted as being an absent member. I think the absent members missed noting that I was absent.
Oh, okay. So noted.
Other than that, I can move to approve the minutes with that amendment.
I'll second that.
Okay, we have a motion and a second. All those in favor say aye.
Hi.
Aye.
Hi.
Any opposed, say nay. All right, motion carries. If you move to tab 2 in your book, we have public comment. Since our last meeting, we received 2 written public comments. These comments are included, they included support of our mission and encouragement to keep working towards our goals. Commission members received these written public comments as part of the full meeting packet last Friday for review. Individuals may also provide public comment during the meeting, and we will hear from them now.
All right. Do you want me to call on folks? We did hear from folks ahead of time who signed up for public comment, so we will call on those people in the order in which we heard from them, and then we will open it up to broader public comment if more folks want to comment. So the first person who signed up is Ronnie Shore. So when you are unmuted, please say your name. If you are affiliated with an organization, please let us know that. And Ronnie.
My name is Ronnie Shore. I'm president of Healthcare for All Washington. Thank you for Chair Lowe and members of the commission for letting me speak. Healthcare for All Washington is the oldest grassroots organization in Washington, and I'm one of the oldest members. We support the work that the Universal Healthcare Commission has completed and the work that they have planned for the future. You have planned for the future. This is a critical time to support even the transitional solutions to save the safety net for the Washingtonians in need, because federal cuts in Medicaid and our health benefit exchange can lead to failure of our commitment, our moral commitment to provide this safety net. You have invited healthcare advocacy groups like us to participate more actively in your work. So we have submitted some transitional solutions in writing, but to add to your legislative report this year. Please consider adding these to the legislation report. There are 4 or 5 basic things, and it looks like I'm not going to have time to go through them unless you give me another minute. Yes? No?
Oh,
Go ahead.
sorry, our
we
mics
forgot
were
to
on.
unmute.
Yes.
Our transitional solutions are based on the work that's already in the draft of your annual legislative report. And one of them is consolidating the purchasing efforts for this public employees and school employees boards to improve the competitive advantage for these public servants to provide healthcare for these public servants. Another is also with the public and school employees boards or plans to promote enrollment of local government entities. While that's available, there are a number of local governments that we hope might consider joining and again improving the competitive bids. The third thing is limitations on the corporate practice of healthcare, legislation that was proposed last year, which would give control to the people who are actually providing the healthcare and would emphasize the role of people over profits in designing systems. And finally, allowing the health benefit exchange to offer standardized cost sharing plans, which they're already doing, but increasing it's an increased or a large number of insurance plans, so increasing competition by having only standardized plans could actually save money for our state and certainly could have an impact on the workload of state employees. So thank you for the work you've done and for continuing to support this commission. So thank you.
Thank you, Ronnie. We're now going to be extending time. Ronnie's time is extended, so everybody's time is going to be extended. We do have more people signed up. The next person that we heard from is Thomas Kennedy.
Hello, my name is Thomas Kennedy, and I'm a volunteer with Whole Washington. We are working on several bills right now that we hope to bring to the legislature over the next few years. These bills range from working with existing bills like the PEB-SEB consolidation bill to a constitutional amendment in favor of healthcare to deprivatization plans for all the publicly administered plans across Washington state. And in order to actually get these done and make them so that they are passable, we need the commission's support to help us work with the legislature and work with the healthcare authority to make plans that transition us towards a future with single-payer universal healthcare. This means we need more meetings with the commission and its members, both publicly and privately. And this is what the community roundtable started. We need to strengthen this sort of coordination between the advocacy movement and the commission moving forward. Please help us with this so we can deliver better healthcare and protect our citizens' access to healthcare, especially in light of the draconian cuts going on right now and increases in insurance prices. Thank you so much for your time, and thank you for your work on the commission.
Yeah.
Hi there I'm sorry, I'm bad at names, to the person who just spoke from Whole Washington. Thomas, can you say again the 3 proposals that you're working on and this sounds a little bit different. Generally it was the Whole Washington Trust, but now it sounds like you're thinking about transitional strategy. So could you just explain that a tiny bit more?
So I only talked about 3 of our strategies. I believe we have about 12 that we're looking at working on over a course of time. The shortest term ones are the ones that are already bills. There are four existing bills that we are looking at working on, the big one being the PEB-SEB consolidation bill, and transitioning that to be deprivatized to protect costs. And we, of course, ideas like Ronnie's for bringing more groups into PEB and SEB as we create a single payer model for PEB and SEB and for the publicly administered plans. And so we have a bunch. We can send them to the commission as we start consolidating our thoughts.
That'd be great. Thanks.
Mm-hmm.
Thank you. Thanks, Jane. The next person on our list that we heard from ahead of time is Annie Fitzgerald.
Hello. Can you hear me okay?
Yes, thanks.
All right. Give me 1 second here. Good afternoon, commissioners. My name is Annie Fitzgerald. I'm a grassroots disability justice organizer from Snohomish County, Nicole, Washington. I'm speaking today to strongly urge you to include quarterly advocates roundtable events in the 2026 UHCC work plan. Disabled people, caregivers, and community advocates are the ones living the daily reality of a system that too often fails us, navigating gaps in coverage, inaccessible care, and constant financial strains just to stay alive. We bring deep lived knowledge of where systems break down and what real solutions look like. Roundtables that center advocates are not just about input, they're about shared power and accountability. They create space for the Commission to hear directly from people who most impacted by inequalities in our current system and to build a plan for universal healthcare that is inclusive, accessible, and rooted in justice. When our voices are invited in early and often, the outcome is stronger, fairer, and grounded in real-world experience. Please ensure that the 2026 work plan includes quarterly advocates roundtables throughout the year to stay in contact with and ensure accountability to the public. Disabled people and grassroots advocates deserve a seat at the table where our lives are being discussed. Thank you for the work that you've done so far and your commitment to building a healthcare system that truly serves all of us.
Thank you, Annie. The next person we have who signed up is Juwaria Sheikh. And my apologies if I mispronounced your name. This person here. I'm not sure the person is here. Let's see.
I see that name in the chat.
Okay. Oh, yes. I think you now can unmute yourself if you'd like to offer your comment.
Is it my turn?
Yes, it is.
Oh, okay,
Oh,
sorry.
my apologies if I mispronounced your name.
Oh, no worries. I think the audio cut out on my end. Okay. Hi, commissioners. My name is Juwaria, and I'm a healthcare intern at Washington CANT. I'm here today to advocate for a single-payer healthcare system for all Washingtonians. When I was a high schooler, my mom lost her health insurance during the pandemic simply because my dad earned slightly over Medicaid's income threshold. Her experience opened my eyes to the reality of health inequities, and as a young student, I felt helpless. Due to her experience and knowing that there are others who currently deal with or have once dealt with the same cards my mom faced, has made me pursue a career in public health and work to reimagine what our healthcare system could be for ourselves, our communities, and our state. So many people's health will get worse due to cuts in federal funding, which is why systemic reform and the work of this commission is so urgent. On our way there, we need transitional solutions to make healthcare affordable for all, with administrative simplification to reduce overhead and stronger price controls, which is essential to reducing costs for patients and taxpayers, because no one should have to choose between health or survival. Thank you for your time.
Thank you for your comment. The next person we have is Paul Villanueva.
Hello, can anyone hear me?
Yep, we can.
Hi, and I can start. My name is Paul Ryan Villanueva, and I am with the Asian Pacific American Labor Alliance Seattle chapter. We are a labor constituency group that bridges Asian American, Native Hawaiian, Pacific Islander workers and organized labor. I am here to emphasize the urgency of the Universal Healthcare Commission's mission to create a universal healthcare system. Further, I am asking the Commission to build in engagement with organized labor and marginalized workers into its work plan. Growing up in an immigrant family, I know the difficulty of getting access to healthcare. This issue runs deep in my community because it affects all of us. From navigating our broken system to paying high medical and prescription costs, it's even harder now to access healthcare when immigrants are being attacked in this country and healthcare data is used to target individuals for deportation. I am mostly concerned about the recent incident in our state where data has been given to the Department of Homeland Security for immigration enforcement. It is the betrayal of trust of those who opted in our healthcare system to get the care they need. Given all the federal uncertainty, the stakes of this commission's work could not be higher. As we build a universal healthcare system, we also build trust in the community. Therefore, I am asking that the Commission hold more advocacy roundtables in the future and continue to consult organizations that represent the voices of marginalized workers and unions. We can't make progress on healthcare issues without talking about workers and immigrant issues. Thank you.
Thank you very much. We have one more person who contacted us ahead of time to sign up to speak. I don't know if I see the name. It's Mahati Alapali. And I do see in the attendees a 425 number, and I'm not quite sure who that is. Okay, Mahati?
Hi, can you hear me?
Oh, there we go. Thank you.
Awesome. Hi, my name is Mahati Alapali. I'm a resident of the Seattle area, and I'm also an advisory board member for Whole Washington. And I'm here today to talk about the urgency and how crucial it is to pass universal single-payer healthcare in our state. I want to talk about this from the perspective of the federal and state Medicaid cuts affecting students at the university level, both undergraduates and graduate students. As we know, the new changes to the Medicaid program are work requirements that span working, volunteering, or being in classes for at least 80 hours per month. Also reducing eligibility for non-citizens, including international students, and changing re-enrollment frequencies to every 6 months. So all of these affect our university students adversely in that many of our students are not enrolled in classes for that many hours per month, and cuts to universities have made it hard to find student employment, which would make it hard for people to fulfill that work requirement. Additionally, the average age of graduate students at universities is 32, which is well above the maximum age that people can stay on their parents' health insurance plans. So this affects many students who are enrolled. It also affects people's ability to use on-campus healthcare due to cuts because those programs are being defunded as well. And it also makes it more difficult for people, especially in rural universities, to access this healthcare because those cuts disproportionately affect healthcare institutions in rural Washington. I just wanted to call attention to how urgent it is to pass a long-term solution that will ensure that these people receive adequate health care that does not depend on the whims of whoever is in power at our federal government and state governments. Yeah, and that's all I had to say. Thank you so much for your time.
Thank you. Okay, and those are the folks who contacted us ahead of time. Now we'll open it up to other people who are in attendance. If you want to speak, please raise your hand and we can move you over to panelist. Looks like Catherine Lewandowski. Hold on, we'll get you moved over, Catherine.
I think I am.
Oh, you are. Oh, you
Yeah.
are.
They moved me over right early, which was kind of nice. Anyway, so I'll go ahead and start, okay? Thank you, Chair Lowe and members of the commission. For the record, my name is Catherine Lewandowski. I'm a registered nurse retired from Arlington, Washington. I volunteer as a board vice chair of Whole Washington, and I'm a volunteer board treasurer for One Pair States. We all appreciate and thank you for all the work you do on this commission. I want to thank you for keeping the actuarial stipend on the agenda, and I want to mention that Whole Washington just had another public town hall in OMAC this last weekend. The folks there are very concerned about their ability to access healthcare. It was interesting to note that they are part of CD4 and they are represented by Representative Newhouse. They live in a CD with a huge number of uninsured citizens, not the top, but the next level down. The most people on Medicaid in the state, and they include the most number of hospitals at risk of closing due to the proposed federal Medicaid cuts. We had more great recommendations from them, and I wanted to highlight a few. First, where in the Washington Health Trust language, we have a sliding scale for the healthcare assessments for businesses with breakpoints at gross revenue of less than 1 million for micro businesses and 1 to 3 million for mini businesses. They reminded us that federally, a small business is considered anything under 7 million in revenue. So maybe the definition of micro and mini businesses needs to be adjusted upwards. During the actuarial, I would think it would be fairly easy to use several calculations to further define those breakpoints. Their other concern is that they fear that companies like Walmart, who are known to push their employees into the public systems instead of providing insurance coverage to all their employees, they feared that those companies would continue to pay poverty wages and then force their employees to pick up the 2% employee share. We think it would be reasonable to say that if a company was not paying wages that were at least 300% of the poverty level at 40 hours per week, maybe they should be required to pick up the employee portion. Lastly, I want to say that our town halls have been very informative, and I wonder if the commission would be interested in collaborating on some joint town hall citizen listening sessions. Probably online would make them the most accessible to people all over the state. They've been well worth the time and efforts we put into them to try and truly understand their issues. And thank you again for allowing me to speak. I apologize for not signing up in advance.
Thank you. No need to apologize. This is the part of the meeting where people put their hand up. Are there any other hands up? I seem to have changed my view inadvertently. Are there any other hands up? Anyone else who wants to offer a comment? All right, well, I'm not seeing any, so thank you all very much for attending today and offering your thoughts.
Yes, thank you, everyone. And as a reminder, the commission welcomes and encourages public comment and appreciates all the feedback we've received. Public comment is an essential part of this process as it provides an opportunity for the public to have their voices heard at regular meetings. Public comments can be provided orally during the meeting or in written form at any time to the commission's inbox, HCA Universal HCC at hca.wa.gov. And I believe somebody will drop that in the chat for you. Oral public comments are not accepted outside the public comment period. Commission members review and consider all public comments received, but generally will not respond to public comments during the meetings. And I know we've had feedback about that. It's awkward for us too. If the commission deems it appropriate, a response will be provided, which we saw an example of today from Jane. So thank you for your patience about that. So next we will hear report outs from our commission members. And so the our members who work for state agencies will offer time for them to give updates first. And I guess in no particular order, Joan, you're first.
Sure. Hey, everyone. Good afternoon. Joan Altman. I work at the Washington Health Benefit Exchange. Quick updates from our end. There are, I really appreciate the public comment today. I found a lot of it really insightful, and particularly comments around some of the population-specific impacts that wouldn't necessarily be as evident to us, like, particularly international students and others that I think we need to lift up, and really being informed about specific population impacts helps us pull all the way up to then think about informing a system that doesn't exacerbate some of the disparities and some of the challenges that we see today. For the disparate impacts that are impacting immigrant populations, I work on that directly as part of my portfolio. We're tracking several initiatives that are coming into effect, either just started or will be in effect for 2026, that are going to impact thousands of people here in Washington. So anyone enrolled in the Deferred Action Childhood Arrival Program who are getting federal subsidies, it's about 300 people here in Washington. They lost access to those federal subsidies as of October 1st. So we've been engaging with that community and working with CBOs and our sister network to try to make sure that people are connected to our state premium subsidy, and also connected to sponsorship programs that could help them in terms of mitigating this, hundreds of dollars more per month that they would need to be paying to maintain health coverage for the remainder of 2025. The second sort of immigrant population are lower income immigrants. Everyone under 100% of the federal poverty level who can't get on Medicaid because of their immigration status, and they've been able to come onto the exchange and benefit from federal subsidies, are losing those subsidies effective January 1. That's about 10,000 people who will be losing those subsidies, and we're sending notices now to let them know that on top of the premium increases they would be seeing anyway in the individual market, they'll be seeing the additional significant increase because of the loss of federal subsidies. And then, of course, we're continuing to be engaged with efforts at the federal level as part of the current shutdown to understand the impact of expanding federal tax credits for another year. Expanded tax credits, they are expiring at the end of this year unless action is taken to expand them further. And we're also, we released our state subsidy premium amounts for 2026. That program at the state level, that funding expires at the end of 26 as well. So again, a timely moment to be talking about impact of federal cuts, impact of state prioritization efforts. And we're lucky in Washington, we've put in place some mitigations that are helping people stay enrolled. We haven't seen, we'll be watching our DACA customers, and we'll be watching our under 100% federal poverty level folks to see how this transition into 2026 goes, and if we're losing people or folks are able to retain, but we're asking people to pay a large percentage of their household income to stay covered in the exchange. So we know affordability barriers persist and are increasing. We're also right on the cusp of open enrollment. So anyone who needs or gets their insurance through the exchange, November 1st to January 15th, you can come in and shop plans and look around. And if you're eligible for those federal savings or state savings, we'll automatically apply them for you. So happy almost open enrollment to everybody. Vicki, I'll pass the mic.
Oh, Nicole has a question.
Oh, just real
Or
quick,
comment.
Joan, for the DACA recipients, how many people did you say were on that plan?
There were about 300 people who were enrolled in the DACA. I think Washington has close to 15,000 or so total DACA recipients, but there are about 300 who get their coverage through the exchange and are benefiting from federal subsidies, who are losing those subsidies, and they lost them about a week ago. So we're working to see, and an example of a mitigation effort that we're excited about is that we were able to work with King County. King County had a little bit of funding available where they're able to wrap premiums for the people who lost federal subsidies to help maintain coverage for DACA recipients and others. So looking to sort of just maximally leverage all the public-private funding we can to at least hopefully get people through the year and then take another look as we move into 26.
Thank you.
Sure. That's our smallest group, so that one seems, that's the most immediate, but the smallest, we go 300 as of October 1, 10,000 losing as of Jan 1, and then another 15,000 losing as of Jan 1, 2027. And that's just in the exchange. That's not talking about Medicaid or the people getting kicked out of Medicare.
All right, thank you. Any other questions, comments? All right, we have Jane here from the Office of the Insurance Commissioner, and we also have the Commissioner, so I'm a little confused.
I'll go ahead, I think, unless the commissioner jumps in. Joan, in terms of your numbers of the folks who are affected by virtue of no longer being eligible either for APTCs or to get coverage through the exchange, we have the impact, like Joan said, of the folks who are going to get their notices because of the expiration of the enhanced premium tax credits. And that could be tens of thousands of people as of January 1 of 26. And we've been working very closely with the Health Benefit Exchange. We adopted a rule, an emergency rule for next year to, we hope, soften the impact of the end of the enhanced premium tax credits so that more people can find that they'll be able to afford their premium. And we'll see what happens beginning November 1 in terms of those impacts. We've also been working, and on the issue of enhanced premium tax credits, we would note that there's an organization called the National Association of Insurance Commissioners, which is the insurance commissioners from all 50 states, red and blue. And that organization has been actively asking Congress to extend the EPTCs. So it is not a purely partisan issue. And we have been working with the State Department of Health on legislation to try to preserve access to the preventive services that folks currently receive, both under Medicaid and the commercial health plans that we regulate and the PEB and SEB programs. So that'll be a bill that will, in some respects, sort of de-link the state from the federal preventive services entities like the Advisory Commission on Advisory Committee on Immunization Practices that is making substantial changes to immunization schedules. And then finally, we are actively working with Senator Robinson on her corporate practice of medicine legislation. The commissioner is a strong supporter of that. And we will be looking for other opportunities next session to address affordability as they arise. So that's it.
Dr. Quangat, do you want to go next? Department of Health?
Yes, happy to go next. Good afternoon, everybody. I can give a couple of updates on vaccines and then an update on WIC. So as far as vaccines, last time I mentioned the West Coast Health Alliance. And the West Coast Health Alliance is a group of 4 states, Washington, Oregon, California, and Hawaii, that come together to elevate the principle that public health policy needs to be based on the best available science. And the Alliance put out guidance for vaccines. First was COVID-19, and then after that, there was guidance on influenza and respiratory syncytial virus, or RSV. And then more recently, the Alliance put out guidance on MMRV, or measles, mumps, rubella, varicella vaccine, which was the recommendations of which ACIP changed in its most recent vote. And in all of these cases, the Alliance pointed to recommendations from the American Academy of Pediatrics, which has a long history of developing evidence-based vaccine guidance. The Alliance endorsed AAP as as one of the sources of evidence-based guidance for vaccines. The other thing I'll mention is COVID-19 vaccine. As you know, the Department of Health issued a standing order for COVID-19 vaccine, allowing pharmacists to administer COVID-19 vaccine to anybody 6 months and older. And I'm happy to report that although there were many reports coming in from the Department of Health that it was still being very difficult for ordinary Washingtonians to get vaccinated in the pharmacies, that we are now seeing much fewer, and hearing from pharmacists that they are giving much more COVID-19 vaccine. There are a couple of rumors really that I just want to correct. One is that the West Coast Health Alliance is issuing mandates or requirements, and that's not true. And the standing order also does not issue any mandates or requirements. The standing order is just a prescription that people can choose to use or not. The other rumor is that the standing order doesn't respect parental autonomy, that children are able to get COVID-19 vaccine without parental consent. And that's not true either. Just as with other vaccines, parental consent is required for children to receive COVID-19 vaccine per the statewide standing order. One update on WIC, which is probably the biggest impact of the federal shutdown on the Department of Health. The Department of Health this week has had to start temporary layoffs or reduced hours for about 50 staff. And most of these people work for our Office of Nutrition Services, which administers WIC. And WIC, the Women Infant Children Food Program, is hugely important to the nutrition of kids in our state. About 1 in 3 babies born in our state receive services from WIC. 36% of kids under 5 and nearly 30% of people during pregnancy receive nutrition support from WIC. The Department of Health has been looking for other sources of funding to extend WIC operations, and feels like current funds will be able to support WIC for another couple weeks. And so the recommendation is that WIC recipients, continue to use their benefits. And that's all the updates I have from the Department of Health. Thank you.
Thank you. Pause for questions or comments. All right, Dave, you want to go next?
Sure. Dave Eisminger here for the Healthcare Authority. There we go. Pulling up a couple of notes I had. Probably comes as no surprise that the agency has a lot of work going on related to HR1 and Medicaid. Looking at sizing options related to the work requirements and the more frequent eligibility reviews. We have a decision package that was part of the agency's submissions last month on resources related to some of these federal requirements. So there's still some refining, but there are components of that. And I just wanted to highlight for everyone that the agency has a presentation on HR1 to Senate Ways and Means next week on the 16th. I was like, that is next week. That's the part I was like, what's today? That is next week on October 16th at Senate Ways and Means. Our agency also continues work on and focus on affordability pieces. Specifically, I'll highlight implementation of Senate Bill 5083, which is the reference-based pricing bill for the PEB and SEB programs. At this point, we have our CR 102 filing made on rulemaking. I think that gets officially published in the Register next week, but our notices have gone about that, and we'll be doing the formal rulemaking comment period related to that. Here over the next couple of weeks, we had a variety of work sessions informally as we were developing the rules leading up to that 102 with a variety of stakeholders. So there's a lot of progress that's been made on that with a goal of having those rules in place ideally by January 1st of 2026 so that they can be relied on as everyone plans for 2027. Yes, it's still only 2025. Let's see. We continue to have focus on maintaining access to coverage and key services with special efforts underway related to areas that have already been highlighted by my colleagues related to immunizations, preventive care, and continuing working on refining prior authorizations. Again, I believe we have a decision package that was submitted on that topic. And yet another decision package I'll highlight is the potential for procurement of fully insured plans in the PEB and SEB programs in the near future. There were lots of discussions at last season's end of season's board meetings by both boards about the potential for expanding competition and potential choice in the portfolios, which would require a procurement. And so there's a decision package about that with an eye towards potentially rebooting the medical portfolios in those two parts of the agency's work by plan year 2028. But again, that's another part of the decision package process. Last, I will highlight something I think that's also been highlighted by some of my colleagues again as well is Senator Robinson's corporate practice of medicine bill. In particular, one upcoming thing that the agency has on the books related to this is a presentation on that on October 23rd at the Health Cost Transparency Board, among other things. But just wanted to highlight our agency's role in interest in pursuing and supporting the discussions and conversation around that piece of legislation. So that's what I've got for today.
Thank you, Dave. Any questions, comments? Any other commissioners have updates they want to share? Representative Schmick, Nicole, thank you.
Just a quick question for Dave. The Robinson bill, is there a number associated with that, or is that a new one? I'm blanking.
5387. I pinched it from Jane. I have my microphone on.
Thank you.
All right. Any other report outs? Representative Parsley, once we got you in here, you didn't get your opportunity to introduce yourself or say hello. So is she?
I'm here.
Okay.
If you guys can hear me above the road noise, it's the trouble of living in Olympia and having an event in Seattle. So I appreciate your tolerance for allowing me to join virtually. I'm just thrilled to be here. I have a lot of catch up to do. I have a lot of learning. I know a lot of work has gone ahead. And I always start out by just listening and learning because I don't want to repeat and reinvent wheels that have already been put in place. At the same time, I'm very passionate about this, both from a medical professional viewpoint, but also because the average person is not only being impacted by HR1, but hearing rumors of healthcare insurance costs going up as high as 75%, regardless of HR1. In certain parts of this country, it is an issue with allowing people to just have a secure home, secure food, be able to afford childcare, be able to do things like go to dinner and movies and so forth. So healthcare is on the mind, and it's not just the shutdown, but it is a major part of people's monthly pay. And so I'd like to be a part of the solution. And that's my political speech. As far as what we're doing right now, and Rep. Schmidt will be able to fill in from his side, but we are just getting an unpacking of HR1 and the impact not only on Washington in terms of service to our community members through Medicaid, Medicare, and the subsidies, but also how's the state of Washington going to be able to afford all this and the impact, especially with our economic forecast. So that's kind of the depressing part, but I'm just thrilled to be here and I'm on a learning journey. Thank you.
Thank you. Representative Schmick, anything to add?
Oh, I'm good. Thank you.
All right, thank you. Just from the tribal side of things, we had our monthly tribal meeting yesterday and had a conversation with Jason McGill about possible Medicaid managed care reprocurement, and still a little ways, no date picked yet. And then we had a listening session on the Rural Health Transformation Grant and heard that rural hospital global budgets are a part of the discussion, which made me very happy and is something that we've had a couple of presentations on here. So I did ask them to make sure to connect with the Universal Health Commission staff. All right. Okay. Is there last call for any other updates? Don't want to miss anybody. All right. If we move to tab 4 in your workbook, Mary is going to talk to us about our work plan updates.
Yeah, good afternoon, everybody. I have today's update. Audrey, if you can go to the next slide. Here's the overview of my update. I'll give you the work plan status. We will review the eligibility straw proposal. As you may recall, it was presented at the last meeting. It was turned back to staff for some edits. We've made those edits, so we are hoping to have a vote on approving that straw proposal today. Also a vote on approving the annual report, the legislative report. We tend to use those names interchangeably. It's due to the legislature on November 1st. And also a quick update on the OIC proviso funding. So if we can go to the next slide. This just is a snapshot again of where we are in the various pieces marching through our work plan. On today's agenda, I just mentioned is the eligibility straw proposal, hoping, we can turn that green by the end of this meeting. Provider reimbursement and participation is also on today's agenda, but that's going to come up when Ross speaks and gives the FTAC update, because FTAC has begun its work on that topic. And also the 2025 annual report, which I just mentioned. So that's what's on this section of the presentation. So Audrey, if we could have the next slide. Real quick review on these straw proposals and how we've put them together. This was in-depth work by a work group that had commission members on it and FTAC members on it. So thank you again to Dave and Joan and Jane, who were our commission members who helped us put these together. We're trying to put together a standardized format for documenting recommendations and decisions. This was created a number of meetings ago. Don't remember when. We'll just say in the past, we got a request, could we please document this and have some standardized way to do this? We modeled it after what our counterparts in Oregon are doing. And this is intended to document our current thinking on a topic. It can be modified, expanded as time goes on. And we are including these in the 2025 annual report. So I'm just going to pause really quickly. If anyone has any feedback about the process itself, this is our first go round. These are our first 2 straw proposals. If there's a better way to get it done, better thing to call it, please let us know. You can let us know now. You can reach out to staff. Okay, not hearing any suggestions. Well, do you have something, Jane?
I don't have any suggestions for changes. I actually it feels very concrete. And even though any of these could potentially be modified at a future point, it's a clear, concrete part of the foundation that we're able to refer back to, and it shows progress. So I think that's great. Thank you for all the work for staff on that.
Thank you. And thanks to the folks who have given us their input. We are, in fact, numbering them as we go along. So giving them official numbers so we can refer back to them. So we're up to number 2. So here we go. So Audrey, if you can go to the next slide. There we go. This is the straw proposal itself. I know the text is a little small as we are looking at it. This was circulated to commission members late September. I don't have the date in mind. We sent out one with track changes because we made some changes following the last meeting. I can just call your attention to a few things that have changed. If you see that paragraph that says recommendations about 2/3 of the way down the page. In our previous version, we had a separate paragraph calling out coverage for people, depending on immigration status. And we changed the approach on that a bit. So now the sentence says, a few sentences in, eligible populations are based on the individual's current healthcare coverage, regardless of immigration status. So that's where that information has been moved in. In a few other places, we have stated more clearly and repeated that it is the ultimate intention to cover everyone in Washington. Although that, then we do talk about eligible populations based on, the likely initial population based on current coverage, but we'd make it clear that that's not the ultimate goal. And Audrey, if you can go to the next page. Language about 1332 changed slightly, and now I'm trying to find it. Allie, do you remember? It's something about, oh, yes. A 1332 state innovation waiver could provide a pathway. And I think we changed it to may provide a pathway. Okay, may provide a pathway and further analysis is needed. So those are the main changes. What we are hoping to do today is kind of a three-part vote. One, vote whether to adopt this straw proposal. This version that you're looking at right now is in the version of the annual report that was circulated with notes saying, we will remove this if it's not approved. So the first two parts of the votes that we are hoping for are whether or not to approve the straw proposal, and then to confirm that it should, if approved, to confirm that it should go into this year's annual report. Hope that was clear. Vicky, I'm going to turn it over to you. Maybe you can make it more clear.
Okay, so we have a progression of 3 votes. The first vote is to approve the updated straw proposal. The second vote, should that pass, would be to approve putting the straw proposal into the report. And then after that, the third vote will be to approve the report and to move it on to the legislature.
There we go.
Any questions? Just about the voting process, and then we'll get into the...
Yeah, and I should add the latest version of the draft annual report is an appendix to the packet. That's where it is.
Okay, no questions about what we're voting on. All right. So vote number 1 is approve the eligibility straw proposal. Is there any discussion on the updated proposal? Dr. Quanget.
I'm sorry, this is more just related to me. Am I approved to vote?
Yes, you are.
Okay, great. Thank you.
Vicki, this is Joan. I just echo the thanks to the staff for incorporating the suggestions, and I think it looks good and reflects our prior conversation. So appreciate the second look at this.
Thank you. If there is no discussion, then we will entertain a motion to approve the updated eligibility straw proposal.
So moved.
Moved by Jane, who's not using her microphone.
So moved.
Seconded.
Seconded by Dave, who uses his, I'm actually got your microphone, Dave, it has your name on it. Seconded by Dave. Any other discussion? All those in favor, please say aye.
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 Any opposed? Say nay.
I oppose.
sorry.
Joe Schmick opposes.
Okay. All right, motion approved. Okay. Are we ready for vote number 2? Is if the straw proposal was approved, so now we're looking at a vote to include it into the 2025 annual report to the legislature. Is there any discussion on that?
Vicky, I just had a question. The prior straw man that we adopted is
Mhm.
report, right? So this would just be joining a second straw man for the report.
Correct.
Thanks.
Mhm. If there is no discussion, then we'll entertain a motion.
So moved.
Okay, we have a motion by Joan.
Second, I've been playing with my mic.
Second by Dave. Any other discussion? All right. All those in favor say aye.
Aye.
Aye. Any opposed say nay.
I oppose. Joe Schmick.
Thank you. The motion is approved. All right, so now we're to our third vote is to approve the 2025 annual report to the legislature. Is there any discussion? All right, if there's no discussion, then we'll entertain a motion.
So moved.
And second.
Okay, we have a motion and a second to approve the 2025 annual report to the legislature. All those in favor say aye.
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 Any opposed?
Joe Schmick opposes.
Thank you. Motion carries. So we have our reports.
Thank you, Vicky. Thank you, everyone. Audrey, if we can go to the next slide. The next slide might be, oh, we already did that one. How about the next slide? Oh, we're so efficient. Okay, here we go. Here's my last topic of the afternoon for now. Is the Office of the Insurance Commissioner proviso funding. We've been getting some questions about this. And it just as a reminder, in the state budget that was passed in the past session, $250,000 of the Insurance Commissioner's regulatory account funds were allocated to create an interagency agreement with the Healthcare Authority to support economic, actuarial, or other modeling related to design of a universal healthcare system. We've been getting questions, do we know quite yet how this money will be used? We don't know yet. No decision has been made, but Commission will provide guidance and FTAC will provide guidance. And we will say thank you again to the Office of the Insurance Commissioner for supporting the Commission's work. And I think that is my last slide. Yep. Thank you all very much.
Thank you, Mary. Audrey, if you could move to the next slide. I'm going to give a Finance Technical Advisory Committee update today. My name is Ross Valori. I'm the Cost Board and Commissions Director here at HCA, and I am providing the FTAC update today because we currently do not have an FTAC lead. So I'll be mentioning that a little bit farther in, but very pleased to be with you today. Just a quick overview of the September 18th FTAC meeting. FTAC received one public comment during that meeting and also discussed provider reimbursement and participation, which is the next topic in our work plan. And finally, just wanting to note for folks that we are currently have a vacancy for the FTAC on FTAC, and just want to encourage folks, if you have any interest, to reach out to staff, and we have that address in the chat. So please feel free to reach out, or if you think that someone would be a great fit for the Finance Technical Advisory Committee, please recommend them, and we'd be happy to reach out. Moving to public comment received. We had one public comment. The public commenter urged FTAC to work toward a system that preserves and increases access to behavioral health care, particularly in schools. Moving to our discussion of provider reimbursement, FTAC members started their work on provider reimbursement and participation. They began with a level set, including a reminder that provider reimbursement is a key component identified in the baseline report. They also had a quick refresher about SB 5083 related to reference-based pricing, which was HCA's agency proposed legislation last year that passed. SB 5083 caps hospital payments for PEB and SEB enrollees, and those are public employees and school employees, and rebalances payments to better fund behavioral health care. The fiscal note for that bill estimates a savings of $290 million between fiscal year 2025 and 2030. Just to note, FTAC requested more information about the implementation of 5083, and staff is coordinating to identify a speaker to bring to the November FTAC meeting. Back to the September meeting, FTAC proposed 2 steps to kick off the provider reimbursement topic. The first is develop a set of guiding principles similar to the principles developed for cost sharing. HCA staff is working on putting together an initial set of principles from various sources and will present those to FTAC in November. The approved cost sharing principles will serve, the approved provider reimbursement principles will serve as a model for the new set of principles. The second part of the preliminary plan regarding provider reimbursement that was discussed at FTAC is to pick a current mechanism such as reference-based pricing or another value-based purchasing mechanism and gradually expand it. Gradual expansion will lead to lessons learned and guide recommendations for universal design. I also wanted to mention something that is not included on this slide, which is that FTAC will also consider ways to pay providers, not just hospitals, when considering provider reimbursement, as we've received that question. Just wanted to clarify that. They will also compare proposed rates to current rates as part of that process in forming a recommendation. Finally, FTAC members are very aware of changes in coverage and funding at the federal level, and they noted a need to be mindful of the current landscape as provider reimbursement is being contemplated for a future universal benefit system. We are very interested in commission feedback on that approach. So just wanted to open it up briefly. If there's any comments from commission members or questions about the proposed approach to provider reimbursement or next steps, or if there's any additional topics or approaches you'd like FTAC to consider as they develop the initial approach to provider reimbursement.
And if I could just jump in really quickly to clarify something. On the previous slide, we said cost containment principles. In fact, it should say cost sharing principles. Apologies for the error. So it's the cost sharing principles that were adopted by the commission that will be our model for how we develop the next set. Thanks.
And my apologies, Mary. Yes. So modeling the provider reimbursement principles off of the cost sharing principles that were used during that portion of the work plan. So apologies for that.
I think I'm the one who made the slide, Ross. You don't need to apologize. I think it was me.
Just a quick peek behind the scenes. Mary and Allie, our wonderful staff, write scripts for us to read. So if you wonder why we seem or why I seem informed, it's certainly because of these two. So very grateful for them. Yes, please.
Okay, so a couple of questions. Could we go back to the previous slide? I'm trying to level set, right? We had the Milliman actuarial study, and as I understand it, that study used a rate for provider payment to cost out what the system writ large would cost that essentially blended, was sort of like a weighted average across Medicaid, commercial health plans, et cetera, although it didn't, if I remember correctly, the base report didn't have the fully insured population that was in sort of the appendix. So it would be, in thinking about provider reimbursement, I'm just trying to put pieces together in my small brain. So if we could have a full understanding of what that weighted average rate is, let's say relative to Medicare, right? And then sort of refresh ourselves in terms of what that weighted rate yielded in terms of the cost to the system overall compared to current state. That would be really helpful because that's like, I think, the most concrete information that we have available to us.
Correct.
Okay, so I know at least I would find that really helpful. And then when we talk about provider reimbursement, what I don't see on here is, are we thinking about whether we want to talk about direct to provider reimbursement or whether we are talking about some sort of managed care contracting? It's almost like the old Universal Healthcare Work Group and the distinction between Model A and Model B. That's a really big decision. Or are we talking about another flavor like primary care case management? So has the FTAC talked about that as sort of being within scope for this, or is that a separate discussion?
I'll let Mary correct me if I'm wrong. My understanding is they did clarify that direct payment to providers was to be included in this conversation, but I don't think that we recognize that distinction, which is very helpful that you pointed out, Jane. So I think that does need to be brought back for their consideration, and just note that that was a point of clarification that the commission was seeking. I don't think we dug that deep.
And then while I'm talking, so I'm thinking about the Healthcare Cost Transparency Board's studies. And Dave, I'm thinking about the work that was done on 5083 in terms of the impact of going to 200% of Medicare for hospitals. Is there information in terms of the analytics that was done on that that would be of value to the FTAC?
I had assumed that the request to level set about the final version of 5083 and current implementation, when my guess is Sarah Whitley or Evan and or both of them come to FTAC, that's going to be my guess as to who the staff will be, that would be insights that they would give. Yeah.
Okay, great. Thanks.
And you're correct. That is planned for the next meeting. It is Evan at the next meeting.
Okay, perfect.
Thank you, Jane. Those are really helpful, and we will bring those recommendations back to FTAC for consideration.
And then, going back to the work group, because I went back and was looking at the work plan that came out of the work group that we're following. I think what came out of it was Model A, like pure single payer, but knowing that we have to get there through Model B, which was still having, insurance and MCOs. So we're looking at Model A with the FTAC, or are we looking at how we're getting there?
My understanding is it's this closer to the second option, but Mary Alley, please correct me if I missed that.
No, I think that's correct.
Okay.
That being ... Can you clarify for me what FTAC's going to be looking at on that?
Costs through using insurance and managed care, but having everybody kind of on the same coverage, or
Right.
everybody covered.
Maybe, Vicky, you can just repeat your question for folks, and then I can respond.
From the Universal Health Care Work Group, what came out of that really, and the work plan that came out of that is what the commission's really been following, was that we want to get to Model A, which was pure single payer, like a giant self-funded plan, right? But knowing that we can't go there directly without causing harm to the system and to people, that we'd have to do it through making changes to how insurance works in the state and expanding coverage where we can. And so as they're looking at this, are they looking at that pure single payer, or are they looking at the step in between, right?
Yeah.
Okay.
Yeah. So, and again, please feel free to correct me if I misstate anything, but A was the more narrowed approach, keeping in mind some of the current federal law that would maybe prohibit, not maybe would prohibit certain groups from participating. That Model B being the more open version that is including some of those groups that weren't included in the Model A analysis. And my understanding, as we're considering provider reimbursement, we are leaning more, FTAC is more considering the Model B, which is the broader group that would include some of those groups that wouldn't necessarily be permitted under current federal law.
So the way I was thinking about Model A and Model B was less about, and I have not read that report in a while, less about who was covered than about how the coverage was provided. So does the governing entity do a competitive procurement and contract with entities like what we call insurers or what we call Medicaid MCOs to actually administer the system? Or does the governing entity use an ASO, an administrative service organization, that's literally just paying claims because our relationships are directly with the providers? So I think, Vicki, the question that you're asking is it because the infrastructure that we have currently is so structured around MCOs and carriers that you sort of start there with thinking about whether you would evolve to direct to consumer? Is that what?
I don't think the work group got to think much past that
That,
because then we
right.
sunsetted.
Right.
But yes, I think, the idea of it being a stepping stone, but also I don't think we have to think about one thing at a time too. I mean, we can look at and we are looking at the transitional steps.
Right.
But in the end, what do we want? And are we planning for that?
So,
yeah.
So to Vicki's point, the thing that I was thinking about too is one of the things that's integral about provider reimbursement is whatever discussion we have about transitional steps around administrative simplification, right? If in sort of transitional thinking, there's more standardization of practice across private insurance, Medicaid, where the state legislature has authority, PEB/CEB, if there's more standardization of practice around things like utilization review that has a goal of reducing providers' administrative burden, how do things like that factor into how much you need to pay a provider? When we think about how much of a provider's time is spent on admin things. So it's that part of it, it seems almost iterative, but it just seems like in terms of guiding principles is what can we assume that, what impact could we assume that administrative simplification would have on a discussion around appropriate provider reimbursement levels?
This is so helpful, Jane, because this is kind of opening up part of the dialogue that happened at that FTAC meeting, which is some of these could be considered part of the governance conversation, which is a little bit further down the work plan. But to your point, Vicki, I don't know if we should necessarily restrain ourselves from considering that when forming particularly the guiding principles. So these are really excellent points, and I think we need to bring these back to FTAC so that that we don't get too confined to the specific part of the work plan we're in, and we are bringing in those concepts and having to make maybe some at least tentative decisions about those governance structures to be able to inform some of this. Thank you, Jane and Vicki. Is there any other feedback on the proposed approach to addressing provider reimbursement guiding principles at FTAC, or any other information you would love us or like us to relay to FTAC? Sorry.
One more comment for me, unless somebody else has something to say. I think it's really important. I know we've talked about this. There's so much work going on already around provider reimbursement, the Healthcare Cost Transparency Board, the primary care, whatever
Advisory
transformation. Yes, thank you.
Oh.
There's the complex discharge task force. Yes. And so I'm just hoping that as we're like doing this work, that the FTAC is maybe made aware of those. And if there's other task force commissions, boards that are going on in the other agencies besides HCA, or even ones that Dave, you know about that we don't know about, that we could make sure that that information gets to the FTAC so they understand, work that's in place. Senator Cleveland sent a list of bills, sorry, I haven't sent it to you guys yet, that they had worked on in the legislature that could be considered steps towards universal health care, but it only went up to 2018. So I think we need to get some more understanding of that, but that might come from the agencies too, because I don't want us to do this with blinders or whatever those are on, want to see the lay of the land, so that I think the idea is to transform from where we are to universal health care. And that will happen through how providers are paid and then how people pay into the system, right? And this is kind of a big step for that.
Exactly. Yes. That's a really great point, Vicki, and we will start working on our end to bring some of that information to the FTAC members, and of course have that also flow up to the Universal Commission as well.
And there might be, Dr. Quangat, things at DOH too, like immunizations you talked about are really important, the preventive services. I mean, technically, access to healthcare is a subset of public health. We've just made it into this big, huge thing, right?
Yeah, we certainly need to find ways to integrate them better and to incentivize collaboration.
Thank you, Vicki. And thank you for Jane and Vicki for giving us these first steps towards doing that. So greatly appreciated. And I think that's all for our FTAC update. If you have any additional thoughts on any of these, please feel free to reach out to us and we'd be happy to relay that down to FTAC. Thank you. Hope everyone has a great day. And I'll hand it back to Vicki to take us on break.
Oh, all right. Let's see. We're early.
Don't jinx us.
Let's take a 10-minute break. And so we'll return at 3:35, 3:37-ish. How's that? Oh, Representative Schmick? Sorry.
I've been listening to this discussion around providers. I was speaking with Providence, and this part of the system over here in Spokane, they have two hospitals, one in Chewelah, one in Colville. 2 years ago, they had a $140 million shortfall with their system over here. They had cut that back to 20 million this year. So they've made progress with the three policy changes, the taxation of providers, with the reference pricing, and then the reduction of 1%. These were all policy decisions made by here in Washington State. That those three items, and I've asked if I can share these numbers, and they said yes. That those three things will add up to an additional 61.1 or $61.5 million loss. So what next year they're looking at 20 million plus 61, that's 80 million. At the end of the day, basically, they're talking about what services are they going to cut out of their hospital system and what's not going to be done. This is reality for a lot of the hospital systems, and it's something I think we've got to take if and be thinking about if our hospitals cannot afford to stay alive, and we're talking about paying them less, where is that difference going to come? Or then the next question is what services are going to end that people are going to expect, but they may not be there. And so I think it's something that needs to be talked about and said, that there are some real ramifications here. I know that with the different boards are working on this. It's not a rosy picture for our hospital system at the moment, and I just wanted to bring that up. Thank you for allowing me to add that to the conversation.
Thank you. Oh, yeah, thank you.
Yes, we always appreciate your perspective. Thank you for sharing it. All right, now we'll go to break and come back at 3:38. So sorry. We were having such good conversations here in the room that we lost track of time. So it is 3:41. I hope you enjoyed your extra 3 minutes. It looks like we're going to go to tab 6 in our packets, and we're going to get an update on the section 1333 interstate compacts that we heard about at our last meeting.
Thank you.
Mary, sorry.
Yep, quite all right. This is going to be a pretty brief update. As Vicky mentioned, we did have presentations about this at the last commission meeting. My apologies, I missed that meeting. Recap, 1333, Section 1333, interstate compacts are a provision of the Affordable Care Act that would allow states to enter into agreements, and it permits the sale of health insurance across state lines, subject to certain restrictions, certain guardrails. Not going to go too deep into those details. CMS has not yet promulgated any regulations related to 1333 compacts, and no state has tried it yet, even though it's been around since the Affordable Care Act was passed. So in September, the presentation was from 2 subject matter experts who talked about what it could do, what it couldn't do, what the next steps might be. And the next steps identified during the September meeting explore the possible intersection of 1332 waiver and 1333 compacts, reach out to our counterparts in Oregon, and ensure that any change would increase coverage and lower the cost. So the next slide gives you the status of where we are. We're in the process of reaching out to counterparts in Oregon, and the definition of counterpart in this one is the Oregon, I don't want to say equivalent, what's it called? Universal Health Plan Governance Board, which is analogous to our Universal Healthcare Commission. And then also there is the Oregon Insurance Office, which is not called the Office of the Insurance Commissioner, and I'm forgetting what it's called. What is it? I'm not sure. Jane is back. Jane will know. The Oregon equivalent of the Office of the Insurance Commissioner, what is it called?
Oregon Health. It's in their Department of Commerce,
Okay.
Banking and Finance or something like that.
Okay.
It's embedded in.
It's embedded. Okay, embedded in their Department of Finance. So getting back to the counterparts, we are in the process of reaching out to set up a work group. And really what we want to do is to explore and track these Section 1333 interstate compacts. There aren't any plans to pursue this at the moment, but it's an interesting idea. It's getting some traction. It's getting some attention. There's other interesting ideas out there. And so what we want to do is learn about things, keep an eye on things, and form this 2-state work group. In our last meeting, some of the commission members who spoke up and said they were interested, and I'm not trying to volunteer you, but the people who spoke up were Joan and Jane and Nicole. I want to confirm those folks are still interested. You don't need to answer it this second. We can take that offline, or if someone else is interested in being part of the group. The only thing we need to be aware of is not creating a quorum. So this work group will keep the commission informed as we learn more about these compacts and other options. Jane, I don't know if you want to add anything to what I just said. Okay. All right, I think that is the end of this. Let's keep. Thank you, Joan.
All right. Thanks, Mary. Excuse me. And now we have our
And Nicole, thank you.
final agenda item. I'll turn it back over to Mary and the rest of the HCA team for a look at the 2026 work plan.
All right, thanks, Vicky. Me again, but I do invite Ross and Allie to jump in as you please. Overview of what this presentation is. We want to talk about the work plan progress. About a year ago, 10 months ago, we presented some priorities and some plans for 2025. I want to check in on how we're doing on that. I realized the other day it's October, which is a little hard to believe. We have some proposed approaches for the 2026 work plan. We're looking for feedback on that. And some ideas to bat around about interim solutions, looking for feedback on that as well. So we can go to the next slide. Hang on one moment. This again is our picture of the 2025 work plan with our pieces in it. And earlier in this meeting, we turned two things green. Eligibility is now green. 2025 ledge report is now green. It's like, you know, when you get to check something off your list, it's pretty satisfying. Provider participation and reimbursement is still with FTAC. Now, early in 2025, we prioritized three key design elements were the three we were hoping to get through this year. Benefits and services, that straw proposal has been adopted. We had cost containment on that list, which we reevaluated how to approach that and decided that it would be woven throughout the other design elements. Provider reimbursement is in progress. Along the way, we wound up revisiting and clarifying eligibility. That was partly influenced by the Milliman report. So we decided we needed to firm that up. And then our goal was to get to financing, which you can see on the left under Universal System Design in early 2026. So the next slide. The workflow we laid out early in the year and that we've pretty much followed was a topic would move from FTAC to the commission to FTAC to the commission, you know, presentation, get the feedback, presentation, feedback. We sort of went back and forth. It worked. It perhaps did not work as quickly as we had hoped. And as you go through these things, other topics come up. So for 2026, what we're proposing is really to break things into parallel work streams, not so much back and forth, but some parallel work. So I'm going to go through some rather dense slides and then hope people can weigh in on this. So the next slide. All right, there's a lot of information here. The bullets to the right are pulling out the pieces of the design elements on the left. So I hope that makes sense. Provider participation and reimbursement. What we are proposing is that FTAC continues its work on this design element. And thank you again, our previous conversation with all the commission feedback. That commission feedback will go to FTAC. They will continue their work. The recommendation to the commission, including guiding principles in early 2026. So that has a little FTAC arrow on it to the left. Then financing. That's the one with the FTAC arrow on it to the left. Sorry about that. Financing goes to FTAC. That takes the lead role in financing in early 26. Again, continue to update the commission on the progress, possible use of OIC proviso funding for an analysis. That's very TBD. You know, analysis may be suggested by the commission, identified by FTAC. And then we are thinking that FTAC is likely to sunset when that set of recommendations are done, when they get through financing. Which takes us down to the next three in this picture, which is enrollment, infrastructure, and governance, which also has come up in conversations today, and sometimes they kind of overlap on each other, as we've noted in previous conversations. So the thought there is to stand up a new committee that would be an operations committee. And they would take on the three topics. The recruitment and the development and the launch of that would happen in 2026. And you'll notice that when I said, you know, take on the three topics and who they would be and how often they would meet and all of that, that is to be determined if this idea flies and if this idea is the correct way to approach it. And we imagine that we would base the charter and the recruitment and the structure currently on how FTAC has been working, just with a different subject matter and a different set of subject matter experts. But we're not reinventing the wheel. I think we would just modify the way we've been doing it. So my next slide talks about then what would the commission be doing? And then I'll pause after this slide to see what people think of this. Is the commission would be focusing on the interim solutions. If you go back to the statute that created, oh, no, sorry about that. I faked you out there, Audrey. If you think of the bill that created the commission, they have the two-part charge, the interim transitional solutions to improve the current system and also work toward the universal design. So what we're thinking is let's send the pieces of universal design to committee work. The commission focuses on interim solutions. And we've talked a lot about various interim solutions, various places to focus. We could prioritize the projects that could serve as pilots for eventual parts of universal design elements. Again, as you mentioned earlier, Vicki, we'll be drawing on the work of other boards and programs, Rural Health Transformation Program, which is ongoing, Healthcare Cost Transparency Board, and others, and then develop recommendations for the legislature to incorporate into the universal design recommendations. So that was a lot of talking and that was a lot of stuff on slides. So I'll pause and just interested in people's feedback about that being our approach for next year.
And so, Mary, this is Vicki. Then we'll still hear from FTAC at every meeting, and they'll be kind of letting us know what they're working on and asking for further guidance, and we'll be giving. So, two parallels, as you said.
Right.
We're not going to, yeah. And we're capable of working on two things at once, I think.
Yeah, the report outs, very much like today, please give us feedback on this and the progress. And then as FTAC sunsets, then we would envision the same structure with the operations committee taking on those other three design elements. We're not trying to invent new things here.
Any thoughts on that approach from commissioners?
Oh,
Dr.
Pongat.
Thanks. I'm new to this committee, so I'm not that familiar with its work, but just in principle, I like the idea of parallel streams of work as opposed to doing things in series when there's no real advantage to doing that. So that's one comment. And then can I make another comment about the guiding principles discussion? And I'm sorry, my brain works very slowly, so sometimes the conversation might have passed when I come up with an idea. But just thinking of Representative Schmick's comments, is there a way that as they're creating these guiding principles, that there would be some way to get broad input to make sure that different perspectives are included as as FTAC creates its guiding principles, to make sure that rural hospital health is prioritized, or to incentivize prevention. I'm just wondering if that's something that that could be built into the process, because if a key guiding principle is missing, then we won't get as strong a model or recommendation as we want. So thank you.
Thank you, Dr. Quangat. We could do that in a couple different ways. Just wondering if you have any preferences or if others have thoughts. We could put forward the guiding principles and then use the public comment forum for folks to provide their comments on that, or we could directly reach out to specified groups to get feedback. Not sure if you have a preference or other commission members have a preference on that.
Yeah, I don't have a preference. Thanks.
Okay. And we'll bring that back to the FTAC and see if they have any other ideas for how to incorporate, particularly the rural hospital feedback on provider reimbursement. So thank you again, Dr. Quangat.
And we did have a panel from on the rural hospitals, and I think that was really helpful for me. I don't know about other people, so maybe something like that too for the FTAC.
Yeah, that's a great suggestion, Vicky, to utilize our own rural health, and the Department of Health has a rural health program as well that we could also engage with to make sure that we're getting that perspective included in the guiding principles. So, okay, thank you.
And just, sorry, I don't mean to derail us into an FTAC guiding principle conversation, but we are beginning to develop what we plan to take to FTAC. Thank you for the suggestion, and we will be sure to broaden what we are putting together as our initial list. What we have now is some feedback, some comments we heard at the last FTAC meeting that we've, paraphrased and consolidated. And then also some input we have received from Healthcare for All Washington. The Washington Health Security Trust Bill talks about what I don't know what forgive me, the governing board that they envision, what their guiding principles would be for provider reimbursement. So we are adapting that as well. So I appreciate the suggestion for the other input to add to that.
Thank you.
All right, here are our discussion questions of, the feedback. Just, does this make sense as a way to move forward?
Representative Parsley?
I like it. It's clear, and being new, as I've heard someone else speak, I like the direction we're going, and I like that plan of kind of parallel work, as well as envisioning beyond FTAC. So thank you.
Thank you. Anyone else? Nicole?
Yeah, I think it makes sense to go in that route. I know, especially considering what's been happening with healthcare lately, having some recommendations on the short term would be really helpful, I think, for the legislature to consider.
Thank you. Anyone else? Oh, Dr. Conget.
Yeah, I agree, especially if there are pilots or models that have been tried in other states that have found to be successful. Thanks.
Thank you. Joan.
Thanks, Vicky. Yeah, this is probably jumping a little bit ahead, but definitely looking at mitigation strategies and looking at how we can sort of shore up our current system in light of recent federal losses is definitely sort of interim work that, at least on the agency side, I think several of us are engaged in. So looking at the nexus of that work to sort of broader thinking about how it could inform universal design, I think would be really well timed. So I sort of like increasing the capacity of technical experts who are helping us move the work forward and helping address some of the public comment about needing to sort of do concurrent work, while we're also just, this commission can focus on the realities like Representative Schiff mentioned and others have about what's right in front of us right now, and not wanting to just trying to mitigate coverage losses, but also have that tie to broader universal design. So I think it's well thought out. Appreciate it.
All right. Well, thank you all very much. I think staff has some marching orders now to to fill in these blanks and get them more detail, but I really appreciate the feedback. That's very helpful. We will come back to you at the next meeting with things a little more fleshed out, more specifics. Today we just kind of wanted to throw the idea out there. And so thank you. And I think our next slide is our last slide of the day, but it's kind of a big one. These are transitional solutions that have been mentioned at previous meetings that people might want to focus on. They are up here in no particular order. What we had hoped to do was hear from commission members what might be an area of focus. Joan, you just said mitigation strategies to, address losses in coverage. I think that's probably what the first sub-bullet was saying. So I'm not really sure. I'm just going to open this up, or Vicky, I don't know if you want to lead the discussion of what sounds like the right area of focus to people. I mean, I don't think we can take on all of these in the coming year, but if there's anything that seems like the correct area of focus or further discussion on any of them, again, staff is going to take this back and see what we can do to start fleshing out the ideas and the plan.
And I feel like we definitely already heard that stabilize our current system and identify mitigating strategies is definitely something people are interested in. And might be what some side conversations have been. Oh, Rep. Parsley.
Maybe it's because I serve on finance committee and we're looking at HR1 backfilling. I think we need to really begin that deep dive conversation into financing and what's the revenue? Because without that, this is all wishes.
Thank you. So I'm just gonna, based on conversation, say the first one definitely on the list. Anybody feel differently?
Nicole's hand.
Oh, Nicole?
I agree. Mitigation strategies is going to be top of mind, I think, for most people, and then closely followed by the financial underpinnings of the system in general.
On rural healthcare, let's note that the Rural Health Transformation Program, once it's submitted to and approved by the federal government, is the commitment by the state to a 5-year approach to stabilizing the rural health system. So it almost seems like if that commitment's being made to stabilize the system, how do we integrate what's in that plan into our planning? So, right, because it brings additional resources. So rather than saying address healthcare workforce needs in rural areas, there are so many potential aspects of the Rural Health Transformation Fund that I would say we work around that rather than we drive it at this point on rural health. Dave, what do you think?
Completely agree with you, Jane.
Okay.
I don't have any other better way to say it.
And that grant will be submitted at the beginning of December, is that right?
November, I think it's November 5th, isn't that when it's due?
Oh,
And then the Fed.
So we'll know very soon.
We'll know the decisions on the first tranche, the tranche that is supposed to be divided equally among the states, is due out December 31st. So, and in terms of financial underpinning, this seems to me the fit for the admin simp discussions, right? Because admin simp administration is a fundamental component of the system that we have to finance. And so, and there has been a lot of interest on that. And I think Healthcare for All has that on its list of requests to us. And then also noting that there was a prior authorization bill last session that didn't pass, 5395, and I know that Senator Orwell is interested in continuing discussions on that piece of legislation. Can I ask you a question about the state option Medicare Advantage plan? And I thought isn't the Healthy San Francisco model broader than Medicare Advantage?
Mm-hmm.
Okay.
Yes, yeah, you're right, Jane. I think that was the most comparable option that we could find when kind of trying to think of what a universal benefit what a incremental universal benefit might look like, something like that.
Yeah.
And maybe that using universal is probably a misnomer there. What a benefit plan might look like that offered some portion of benefits, but not a full health plan.
Okay. You can also look to the history on the basic health plan because that was not a rich benefit package.
Okay.
But
It was good coverage.
yeah. But it wasn't Medicaid. It wasn't as big as
Became
Medicaid.
Medicaid later, but yes.
Right.
That was something I put out there just because I know that like with the Medicare Advantage plans, you get some of the premium A and B.
Mhm.
And that would actually bring money into the state instead of,
Oh, I see what you're saying.
making it out of nothing. So I was trying to be creative to bring more money into the state.
Okay.
And I think if we do it, you can't require people to do it, and that it just is a good benefit package. I know that it must work well because the plans that do Medicare Advantage are pretty aggressive in trying to get people enrolled. So I just think it's one of the things that we could think of that actually brings money into the state. Oh, sorry, Nicole.
Just a quick question. I don't know who would be able to answer this, but the basic health plan that still exists in statute, it's just not funded. Is that correct?
Yeah, the basic health plan basically was cut back drastically during the 2009-2011 recession. And then once the Affordable Care Act passed, the folks who would have been BHP enrollees became either Medicaid eligible or eligible to purchase coverage through the exchange.
I'll
Thank
just
you.
I'll just chime in that I think the answer is mostly yes. Over the last 15 years, I believe various cleanup bills have decodified some references, but there are still many that are in statute. So I don't know if the parts that might have been decodified would be seen as central or not. And so I just caution that I don't think all the statutory references that existed 15 years ago exist, even though most of them I think still exist.
Representative Schmick, I saw your hand up. There you go.
Thank you. Could you explain a little bit more how a state option Medicare Advantage plan would bring money into the state? I'm not following how that would work.
Sure. So there's, Medicare A, B, C, and D, right? Medicare Advantage is Medicare C, and those plans take the place of your Medicare with like Medicare A is hospital, B is like physicians, outpatients, and then you buy a supplemental. But with a Medicare Advantage plan, you purchase from an insurer and they pay your whole claim. So nothing goes to Medicare anymore. And then you pay like a copay. But what happens with those plans is they get some of your A and B premium that was going to Medicare. And then they charge a premium to the client or participant. Does that make sense?
Let me take a crack at it.
You want to take a crack at it, Jane?
Yeah, we had a work session on that in the healthcare committee,
right,
around Medicare Advantage plans, and a lot of people that had bought those, when they start to go use them, find that there's all kinds of co-pays and other things involved to where they're not getting what they thought that they were getting in compared to just a Medicare supplement plan. That's why I was curious about how that was going to bring in more money into the state.
Well, from the premiums, but I think if a state-run plan, then we can make sure there's more providers available. And then we choose the copays, right, Jane?
Right. So in a Medicare Advantage plan, the Medicare Advantage plans receive a monthly payment for each enrollee from the federal government. So that's the revenue that comes in. And Rep. Schmick, your point is very well taken about the concerns that consumers have about Medicare Advantage plans in terms of narrower provider networks, more prior authorization requirements, right? All of those things. And the really big question is, could you design a Medicare Advantage plan that lives within the amount of money that the feds will give you per person per month, and try to avoid some of those plan design features that are least appealing to the people who get coverage from the Medicare Advantage plan and then find out that they're not as happy as they thought they were going to be. Does that help?
Yeah, I don't know how the state is going to design a plan. I guess it would be interesting to see how that would play out. To see if that really is able to accomplish that.
Good question.
Oh, I don't see any hands. Okay. So I think we've talked about quite a few of these, and thank you very much. The very bottom one on the page is about SHOP, Small Business Health Options Program. And, oh wait, is someone's hand up and I'm missing it?
No.
No. Okay. We did have some internal conversation about this. Is this about SHOP specifically? Is this about how to address small employers, how to help small employers provide insurance coverage? Just wondering if anyone has any thoughts or comments on that. It's the one we haven't quite gotten to yet.
Well, this one also came from me. But I was thinking more like a uniform medical plan look-alike that's available for businesses. And I know that there's the small businesses. I run a small nonprofit, and our insurance premiums are pretty awful, but I feel very compelled that we provide those for our employees. So as a way to maybe start building the universal health plan. Does that make sense? So it would be like uniform medical plan, but it wouldn't be uniform medical plan because that's what we looked at, right? For the Milliman report and then be a self-funded plan offered to small businesses.
Oh, self-funded.
Mm-hmm.
Okay.
Representative Schmick.
Well, correct me if I'm wrong, but as I recall that SHOP program, there wasn't a lot of uptake in the marketplace for that. Am I mistaken?
Joan, do you want to take that?
Sure, I can say it's been a legislative area of interest in the past. So we previously pulled together some background information and could figure out how to share that out to commission members if it's of broader interest. But yeah, when we launched the exchange, we launched a SHOP program with a whole separate department and platform. And there were a handful of carriers, I think 2 or 3, that came in and offered a SHOP product and it was in existence from 2014 to 2017. And by the time we got to 2017, there weren't any carriers interested in, at the end of it, there weren't any carriers interested in continuing to offer the small group plans just because the value proposition in Washington wasn't strong enough. The participation was pretty limited. The tax benefit is pretty limited. And we have such a strong association market. And here in Washington, it didn't pencil out in quite the same way here as it has in some other states. So we tried for it. That being said, I will say, small business and coverage of small business for small business owners, we know the federal tools like the ICHRAs and QSARAs offer limited relief in their current form. And at the federal, those federal directives sort of acknowledged that there was a gap here, haven't quite filled it. And it's an area of interest to our bipartisan exchange board as well. Folks, we had a panel of small business owners come recently and speak about the challenges they have in using the current federal tools to cover people, and just spoke to the need for, the state and the exchange to continue looking at it. So I do think there's some there, Vicki, in terms of just echoing basically what you said to this group, like finding a plan that is affordable, that covers the range of needs that people might have is really challenging. A way that we've thought about, been working with associations and others and at the exchange, is to sort of offer an ability for an association to help subsidize a premium and to leverage some existing HRA or HSA tools that are there to try to help someone out a little bit. Definitely some federal barriers, but definitely, worth continuing to look for creative solutions around just understanding that it's a persistent issue. So it's one that's come up in our world too.
Yeah. And then when we had the advocates roundtable, we did hear that labor was interested in universal health plan. And so I'm wondering if something like that could bring labor to the table. And that's where we get into enough risk to actually have a plan, I think. And I don't know, Nicole, what you think about that.
Possible. I'd have to go back and re-review the whenever you guys met. I was absent that day.
Oh, that's right. Sorry.
Yeah. Yeah.
Yeah. So that's just, I think that we have plans to maybe bring some labor conversations to the commission too. Yeah.
But I also think and Nicole, tell me if I'm off base here, right? When there's talking to labor unions, but a number of labor unions have self-funded Taft-Hartley plans, and there's very strong commitment to those plans. So I think any discussion with labor is a discussion that encompasses not only the union organization, but also the perspective of the Taft-Hartleys.
That's correct.
And then just one more onion layer, just to remind people that some of the large public sector unions actually have the ability and do contract into PEB. So, for example, the Federation's own employees are part of PEB. Public school employees of Washington's own employees are part of PEB. So there's that layer. I'm glad you brought up the Taft-Hartley, because I was going to say that too. So, but just adding in the other civil service represented employees, or organizations that represent civil service employees are eligible to contract into PEB and SEB actually, but we don't have any in SEB yet.
And actually, so are tribes.
Yes. Yes, so are tribes. I think we have 6 or 7 tribal organizations.
Yeah. And I'll just jump in again to say thank you for the comments and the input from folks. We are looking ahead to the December meeting and have been thinking that there would be a labor panel, labor discussion. We haven't filled in the details yet, but you are helping us do that. So thank you.
All right. Any other comments? Is it permissible to ask if they want to add anything to the list? Is there something missing on this list? We do have 40 minutes. So.
Nothing more?
All right. And again, a reminder, if you think of things after the meeting, I too, when I'm driving home, will be like, oh no, I forgot to say that. So feel free to email staff or get a hold of them and let them know. And did you have something wrong?
Was just going to add, just since we have a moment, regarding look at the financial underpinnings, just to give some insight into what the cost board is contemplating, thinking about in 2026. Is a lot of focus on market oversight, and a lot of the concepts that have already been talked about: corporate practice of medicine, Keep Our Care Act, which is focused on increased oversight of mergers and acquisitions, and incorporating some newer iterations on that with private equity, and just more transparency regarding ownership structures. Also looking at or continuing work related to provider registry and the state health plan. So just to give folks an understanding of what we kind of are meaning by financial underpinnings with the current system, just to add some more detail to that provision, since we had a moment, and happy to answer any questions if there are any on that point.
Okay, if there are no other comments, I think we can close the meeting. So the recording and summary of this meeting will be posted shortly on the HCA's webpage for the commission. Our next meeting is Thursday, December 11th from 2 to 5 p.m. We look forward to seeing you all then. Thank you. Oh, no, it was the thank you.
Oh, okay.
All right. Have a great evening, everyone. Thank you for all your participation.
Thank you, everyone.